Okay, hello everyone, and welcome to the eighth episode, I think it is, of the Community Health and Capital podcast affiliated with the 19 Hills Community Interest Company. I've got Selva with me today. Hi, Selva.
Hi, Johnny. How are you?
Good, thank you. Thanks for joining. We're glad to have you on.
Thank you. Likewise. Yeah.
Selva is a GP partner at Bromley-by-Bow, and I'm sure he can introduce himself in a second. And I think it's really important we have someone from Bromley-by-Bow with us today, particularly given, as I'm sure it's probably gone into the planning of many of these health and wellbeing centres. Bromley-by-Bow is considered a prototype, visionary, a great example to learn from in terms of how we kind of really bring the community with us, but also deliver integrated care as we do it. I've got the suspicion, Selva, you've probably got so many hats you struggle to fit them on your coat rack when you come home at the end of the day. But why don't you tell us a little bit about yourself before we start?
Absolutely. Thanks, Johnny. So I've been a GP partner at Bromley-by-Bow Health for about 10 and a half years now. And this was and prior to that, I was a salaried GP, and I've been looking for a partnership like this that integrates community health, NHS general practice together. So Bromley-by-Bow was one of the first health and wellbeing centres in the UK, founded over 40 years ago, and we just celebrated our Bromley-by-Bow Centre's 40th anniversary, and kind of a trip down the memory lane as to the amazing work the centre and then the health centre, which then became a part of it, have done in how we address and create healthier communities. So along with being a GP partner at Bromley-by-Bow, which is we're spread across 4 sites and we serve about 51,000 patients in our corner of East London. And it's a deprived population. About half of our population live in social housing. And we see the effects of poverty. So half the kids, about 55% child poverty, one of the highest, I think, alongside the black parts of Blackpool. So there are lots of challenges, and people become ill at a much younger age. So it's not surprising to have people in their 20s with type 2 diabetes, people in their 30s having an MI, and then ending up with a chronic kidney disease in their 40s. And by the time they're in their 50s, they're on about 20, 30 different medications. So lots of challenges for our population. And that's what led to us thinking about how do we, uh, rather than just medicalize their conditions, how do we actually create healthy communities and address these things much early on? So along with kind of being part of that journey, I also am a medical educator, so I support international medical graduate GP trainees in London who face lots of challenges of their own, including exam performance, career progression, and so on. So that's one of my roles, and I'm also within the National Council of the RCGP and the BMA, where I get the opportunity to work with amazing colleagues to deliver some national work for general practice. So those are some of my hats. But I think the one I really, really enjoy is actually being a jobbing GP and being part of the missions and values at Bromley-by-Bow.
And you've missed out probably the being the first person to identify how to clone yourself to manage to fit all that into 7 days a week. Thanks, Silva. And I mean, God, most people
Yeah.
must know some of the story of Bromley-by-Bow, and it's always a surprise if you come across if someone hasn't heard of yourselves. And I shouldn't do this podcast without expressing a lot of jealousy, really, because I think it must be such a really
Thank you.
exciting,
Yeah.
inspiring place to work in. But although many places have looked up to or maybe sought to replicate what you guys have done, there is quite a story in the journey of that 40 years, isn't there? And I just wonder if you could maybe just describe that kind of from where you're sitting and how that's got to where you are today.
Absolutely. As I said earlier, I've only been part of a quarter of that journey of 40 years. I've been there for 10 years. So there's some amazing individuals like Sam Everington, Julia Davis, who are our founding partners, along with Andrew Mawson, and lots of other non-medical people who have been involved. Lord Mawson, Andrew, he came as a priest in the 1980s to our corner of East London. This is post-colonial Docklands area, very deprived, so all the industry's gone. And he was seeing how people were getting ill much early on, and there's lots of other wider societal issues as well. And that's when he looked at who are the proactive GPs, innovative GPs in the area. And Sam and Julia came on board at that time, and they really were the forerunners of setting up one of the first health and well-being centres in the UK, where rather than just dealing with patients in a transactional and holistic way that's general practice was going, we looked at how do we actually intervene at a much earlier stage in our communities, and how do we actually become very deeply rooted to our communities, and so that's where the journey started, and it's expanded. The concept of social prescribing was established. We're not so fond of the term social prescribing because it kind of still medicalizes what needs to be done. But the name stuck, and now is part of all the GP contracts via the PCNs in England. And I know you guys are doing some exciting works in Wales, and I've spoken to Scottish colleagues as well who have similar ventures. So it's really great to see the kind of the values we hold dear are now established in lots of other areas as well. Um, so the kind of social prescribing was our kind of first venture. Now, I think we're in our kind of second stage. We we have one of the first population health contracts in England. So our local integrated care board has awarded a 15-year contract for us alongside of our traditional GP contract, which enables us to work with it's funded for 15 years. We started in 2022, enables us to work with the council, the housing association, local charities, the pharmacies, and any other community organization, and especially schools as well, with a view to how do we create healthier communities. So I'll tell you, one of the work streams we're doing at the moment is really exciting, is actually working with schools. So we've got we've got students at the moment who are in a month-long summer placement program where they get to experience careers in health and social care. So it's not just about, traditionally it's been about work experience for people who want to be doctors. So we've kind of moved beyond that, saying, if you want a career as a administrator, as a manager in a GP practice, or as a social prescriber, as a health trainer, as a GP, as a nurse. So we offer placements. So we've got several students who are with us at the moment, and they've been helping us. And we then work with the local schools as well. So our teams go out to the schools, do various talks, and get all this embedded within our communities. There's also lots of exciting work happening around how do we address childhood obesity. So we have more than half of our secondary school kids who are overweight or obese locally, and I completely recognize as a kind of a single organization, we can't tackle this. There needs to be regulatory and other changes to address our obesogenic environment. But we're making a start, and it's been really great to have the ICB recognize that population health needs to be a core part of NHS general practice. Because we as GPs, I often talk about this. We're doing 20% more activity than 2019, but the whole data shows patients are dying earlier. Hospital waiting lists are getting longer and longer. We've got more and more patients being added to our chronic diseases register. So activity doesn't necessarily equal better health for the nation. So thinking about how do we actually stop people from getting ill in the first place by creating healthier communities, and when they do become ill, if they do become ill, how do we actually stop that chronic diseases from progressing? Uh, and it's great to see. So Stephen Kinnock, who's the Minister for Social Care and Primary Care, he visited us 2 weeks ago and looked at some of the missions that we're doing. It's really great to see the new UK government actually focusing on the population health aspects of how we deliver more sustainable healthcare. Because at the moment we spend a lot more on reactive health.
We do, don't we? Yeah.
Very about less than 2.5% of the NHS budget is spent on proactive health. We really need to flip that ratio.
And it's an interesting contract and setup, I suppose, isn't it? I'm presuming there aren't any other practices or organisations that may perhaps have been giving anything like that. But it's also interesting the longevity of it, I suppose, given how long third sector organisations have complained about
Yeah.
having to bid year after year, which affects how sustainable they can be, how successfully they can employ and recruit people. I think it's probably fair to say a lot of frontline NHS community services often feel,
Yeah.
the priorities and agendas might shift from year to year too, and there isn't any consistency for them to do something into the long term.
Yeah, absolutely, Johnny. So that's always been a vulnerability and kind of whenever we have these community services. So, for instance, we used to have a nursery in one of our premises, so where the staff and the local community could drop the kids off, and then they can carry on working in the health centers and in the local areas where they're based. But the funding for the health centers for the nursery stopped. So we've had to get rid of that. And we had a really great employment program with um, one of the city banks, and that's come to an end. So it's always been in throughout the 40 years. We've had to kind of chase these short-term contracts, which then enables us to set up something really exciting. And then when it comes to an end, or there's a change in health policy, um, all that great work is let go and we start again. So it's been really great having this 15-year contract. So what that means is from 2022, we got 15 years to actually embed some of the work that's been happening. And and it also enables you to demonstrate the outcomes as well. Because this is not like this is not about avoiding any attendance. So this is not about we're going to reduce this many number of people going into hospitals by this. This is a long-term project. About we'll only see the work that we've done in about 20 years' time. So having that contract really firms up evaluation as well.
And people listening might not know the intricacies of various different contracts that GP practice have in the UK, but I think I'm right in saying that whereas most practices would have quite a traditional general medical services GMS contract, which follows the unified contract that is negotiated at a national level.
Yeah.
Bromley-by-Bow for some time has had one of these APMS contracts. Is that
That's
fair?
right. Yeah, yeah, absolutely. So there are three main types of contracts. So one is GMS, Generalized Medical Services. Other one is a PMS, Personalized Medical Services. So the PMS was an evolution of the GMS where there was local variation. The GP practice could choose to offer additional services like antenatal care, anticoagulation care, and so on. The APMS was a contract that was introduced in the early 2000s. These are time limited contracts, unlike the GMS and the PMS, which are contracts for life. So these contracts tend to last for anything between 10 to 15 years. So that is a slight disadvantage with these type of contracts. But what this enables us to do is actually bolt on innovative projects, long-term projects. So most APMS contracts in England have been for very transactional way of healthcare. So they've been implemented in urgent treatment centers or GP surgeries, which have been taken over after the previous GPs couldn't run the surgery because of unsustainability. So often it's been practices who haven't been doing great and they've been taken over. So um, we run two APMS practices, and both of which are CQC outstanding. We've maintained that since 2017, despite all the challenges. Um, and that's part of what led the ICB to have confidence in us, along with a pedigree of the Bromley-by-Bow Centre and the health partnership, and us actually running two APMS contracts in a CQC outstanding manner. Then when it came to negotiating the new one in 22, we were able to make a good case for adding population health onto it.
Because I know some people have had their fears around, you know, new and different companies maybe coming in and running these APMS services. There is also, as Bromley's shown, the opportunity to do something innovative and different, and perhaps
Yeah,
to have a more community focused model of services with
yeah,
different organisations from the third sector coming up to be taking on these contracts.
and absolutely. So I think it is absolutely fair to say a lot of the APMS contracts have gone to more corporate type of general practice providers, and they haven't always been rooted in their communities or been interested in community and population health. So there is an opportunity, I think, as the the new government now negotiates with GPC to actually think about how do we encompass this in our existing GMS contract as part of proactive and population health. So because even this 15 years, it is time limited. And one of the major limiting factors is reduction in GP funding. So we've lost about 660 million pounds from the GP contracts in the last since 2018. That's a significant loss. We used to be around 9% of the NHS budget went to general practice. Now we're down to about 6%, despite doing more activity. So what that means is GP practices are struggling. We've got fewer GPs. So as part of investment in general practice, one of the ways that we can deliver sustainable healthcare that ticks the boxes for what the government's trying to do and what the GPs would like as well is actually focus on why don't we focus on population health as part of a core contract for GPs? It's something that I have been advocating for, and hopefully it gets taken on board.
Well, before we get too bogged down discussing contract, which obviously interests and appeals to me and yourself probably, but
Absolutely.
just I suppose we probably didn't credit enough, and I'm sure other people will be involved, but I think it's fair to say Bromley-by-Bow really pioneered the way in whether we want to call it social prescribing or connecting patients with assets in the community and non-medical source of support. I've always been intrigued that Bromley-by-Bow has really made clear that you can't do the social prescribing without making sure people have support for their their basic social needs,
Yeah.
their house, their job, their income, their energy, and the rest of it.
Yeah.
But I think you were saying earlier that as well as delivering that model, there's been some changes in how you deliver social prescribing in general more recently. I just wonder if you could elaborate on that a little bit further.
Absolutely. Social prescribing is where when you see a patient, either at the reception or in a health event or in your consulting room, you recognize they have some needs other than medical issue that's driving some of the ill health. So you would refer reactively to a social prescriber. So what we've done is we've kind of looked at it and say, yeah, we've been doing this for a while, but how else do we actually but yet we're seeing a lot more patients with diabetes, a lot more patients with hypertension. So what are we missing here? So Saul Marmot, one of my partners, and Dan Hopeful, who's our head of insights, which is our research department that deals with kind of the impacts of social prescribing in the community and evaluates. So they came up with the concept of why don't we integrate referral to social prescribing as part of our long-term conditions review. So all of us in England do QOF, and I'm sure in Wales you have a similar system of kind of quality improvement with patients of chronic diseases. So as part of that, we see them every year. They get their blood test done, they get their urine test done, and so on. But what we are not actually doing is what's happening at your home, what's happening with your job. Are your finances in a struggle? Are you stressed? Or do you need any housing support? Do you need any benefits advice? So we've actually integrated proactive questions about social prescribing as part of long-term conditions review. So every template now, a long-term condition template now has social prescribing review as part of it. And so our clinicians, our nurses, our pharmacists who are doing these LTC reviews, long-term condition reviews, are proactively asking about social prescribing. And this has led to 60% increase in referrals. So now we've got the bottleneck of more referrals, but we haven't got enough funding for social prescribers. So it's a nicer problem to have, but it's also created a bit of a bottleneck. So we've actually gone looking for work and uncovered there was a huge demand. But what that's led to is patients being identified early on with their chronic diseases and being offered support. So Northeast London ICB have now integrated that questionnaire as part of every single LTC reviews. And we're having some discussions with RCGP. Hopefully, the college is doing a lot of work around health inequalities and thinking about how we integrate that as part of some of the toolkit recommendations for all the practices. So it's just kind of a new evolution of our social prescribing, and it's been working really well, and great to see it being taken up in Northeast London.
And I suppose it turns on its head because I think GPs have been doing similar work like this for a while, but it's always felt like you're referring out and you're connecting somebody somewhere else, really. Whereas actually, and I suppose the risk with that is that it may dampen how much enthusiasm you're giving to this or how much credibility it has.
Yeah.
Where I suppose this is actually turning it back to say that this is a core and routine part of what we do. It may even be that the person we're referring you to is actually down the corridor from here. They're part of the core long-term condition management team then, really, aren't they?
Absolutely. So the social prescribers and our call. So this question is even being done by our call recall team. So these are the people who actually call to book the appointments with the clinicians. They're administrators. So this has firmly become part of our long-term conditions review. Just like you're checking, have they had their kidney blood test? Have they had their urine test done? And we're now being asking, have they had their social prescribing referrals discussed, and are there any needs that we need to address? So it's become firmly part of a long-term conditions review, and that's been a really positive change and the patient feedback has been really great, Saul's done lots of talks to various health team, and it's been enthusiastically received.
Well, you're going to have some work on your hands to deal with that 60% increase. That's a hell of a lot of work. So I just wonder, I suppose, in kind of a few minutes before we wrap up, Seven, another couple of
Hmm.
questions that just I was thinking through as you were speaking. I
Yeah.
mean, I suppose the first one is kind of touching on, you saying what partnership you were looking for. You were looking for, obviously, an innovative group that wants to do something different. Do you feel there are many kind of practices or partnerships that are in that kind of similar kind of ethos of what Bromley-by-Bow does? And if there's not so many, why is that still not really the case?
I think that's a really great question. So it's Bromley didn't start with a plan. So it's kind of started organically. Some local people coming together. So they actually had an artist studio. So the local artists were looking for a place where they can have a studio and paint, and they came together. And then the local people started coming to it, and so it grew very organically rather than in a planned approach. Um, and then we went to the NHS and say, look, we got this great idea, fund it. Um, NHS um, doesn't do many innovative things, I have to say. We're still practicing in a very medical model way. So and our medical training en kind of ingrains that way of working as well. Um, it's I suppose it's about and with all the GP surgery struggling with funding, to go and say you need to think about this uh, innovative way of working. um, there isn't that time, there isn't that funding, and unless you have a very proactive ICB which says, okay, we need to really invest in population health, the whole mission becomes very challenging. I suppose that's probably why it's been difficult to replicate this everywhere. Um, and this doesn't make profit.
Mm,
So I think that's the other important thing too. So this isn't about uh, profit. This isn't about and you don't see the results of the work for decades. So with NHS working at a very short time frames and policies changing, in England in the last 20 years we've had about three major reorganizations of the NHS. We've just had ICBs established about 2 years ago, and prior to that we had CCGs, and prior to that we had PCTs. So when things change within commissioning that rapidly, it becomes really difficult to do this within an NHS setting. Um, and it's really hard to get the funding to run something like this externally outside of the NHS, because
mm,
this just cost, it will cost millions to set something up
mm,
like this. Now you've got to find the right premises, you've got to get lots of people together. But having said all this, there is a lot more willingness to experiment with something like this, because we are recognizing we're spending about 44p of every £1 of taxpayer or government expenditure on healthcare. And if we just continue spending reactively like this, it's going to be, well, we're going to reach a point where we won't be able to afford it.
mm,
So we do need to flip how we do this. And It's been really great to see, as I said earlier, Stephen Kinnock coming and looking at our population health work. So I'm hoping there'll be a lot more support from the new government in setting up health and wellbeing centres, which integrates health and the communities together.
That would be welcome, wouldn't it? I think
Yeah,
we're probably run out of time now, Selva. But a big thank you for your time and for sharing the journey Bromley-by-Bow has gone down. Some of the quite interesting developments, I think, that have been afoot in Bromley-by-Bow,
yeah,
and I'm sure when we speak again in the future, there'll be plenty more down the road.
absolutely.
Where could people go to if they wanted to find out more about kind of what you guys are up to? What's the best way to?
So probably the best way of doing it is looking at our website, which is bbbc.org.uk, and there are contact details there. And it's a matter of just emailing us. There's a section called Insights, which is our department. Well, I wouldn't like to call it a department. It's a collection of very enthusiastic and innovative people who receive visitors. We get about 2,000 delegates from around the world and around the country every year. So there are workshops, kind of other kind of materials that we have, which we could share with anyone on how to set up similar projects like this. And we've had people from Japan and lots of other parts of the world and the country come over the years. Um, so
Brilliant.
happy to share, happy to spread the mission.
That's brilliant. That's really kind. I think I've had friends of mine that have called it a pilgrimage, and that being the case, I'm probably long overdue one. Well, everybody, this has been the eighth episode of the Community Health and Capital podcast. Thank you to Selva for joining today. We look forward to updating with another episode soon. And if you've got any ideas for podcasts, speakers, topics, themes, feel free to get in contact through our website, social media, or email podcasts@19hills.org. Huge thanks again, Selva, and we look forward to connecting again in the near future.
Thank you, Johnny.